you.
Next, we have Christina from Canada. And Christina, a very interesting project too, particularly focusing on Ontario. Christina is looking at the core principles of integration of healthcare and social services that support continuity of care for vulnerable older people within the Canadian setting of HAL, which is Home at Last. Thank you, Christina.
Thank you very much. I'm delighted to be here and addressing all of you. Unfortunately, my co-presenter was unable to come, but this is really based on her research, Sue Cheng, along with her supervisor, Christina Catalano. So I'm hoping that Sue is at home in Toronto watching the live stream. It's about 3 o'clock in the morning there. But Sue, I hope I do you justice and your research study justice as well. Looking at the phenomenon of integrated health and social service care in Canada is really an emerging area. So there's not a lot of data available yet. And one of the reasons that Cheng and Catalo decided to look at this area. There's a number of different definitions for integrated care, and I'm sure that you're all familiar with them, but for the purposes of this research, Cheng and Catalo developed the fourth one there as an opportunity to look at the continuity of care between different partners. Yesterday, we heard from Professor Shortall, and he referred to the Lutz model of the continuity of care. So this was another lens that Cheng was looking at. They also considered the various domains of integration as presented by Codner. Again, I'm sure that many of you are familiar with those. What they did develop as a result of the literature review that they did and looking at a number of different examples was develop some thematic categories and characteristics of integrated care that then became sort of the lens that they were exploring the Home at Last program that my organization, CHATS, Community and Home Assistance to Seniors, has been operating for a number of years now. Just to put a little context on the Canadian situation, Canada has a federalist model with respect to our healthcare system. Both federal and provincial and territorial governments share responsibility for healthcare. The federal government implements the Canada Health Act, which demands that healthcare in Canada follow several different principles, including universality and portability. And we are considered to have a universal healthcare system to a certain extent. The Health Care Act states that hospital-based services and medically necessary services, primary care predominantly, must be universally accessible irrespective of the province or territory. The rationale and drivers for integrated care, like in so many other jurisdictions around the world, and as we've been hearing throughout this conference, are many. Certainly in Canada and at a provincial level, service delivery is fragmented. There's challenges with transitions between service providers and coordinating services between providers. There's some fundamental differences between the health and social services sector, not the least of which how those two sectors are funded. Some healthcare services are funded through the Ministry of Health, whereas social services are funded through other ministries, but there is sometimes some overlap. In Ontario, we have a new government that came into power last year, and they're very focused now on ending hallway medicine, the phenomenon of not enough beds in hospital and people ending up in hallways of emergency departments or having to retool cafeterias into bed areas and so forth. So the government in Ontario is very, very focused on that now. Recently, they introduced what is being called the People's Healthcare Act, which envisions a transformation where the focus will be on a much greater degree of integration. with the government trying to better connect all the players with respect to helping to avoid patients ending up in hospital inappropriately. So, who is CHAPS? We're a charitable organization that serves a region of about 1.4 million people north of Toronto. We have a geography that's both very urban and dense, as well as a lot of people who live in the rural area. We serve over 8,300 clients in the region, most of whom are female, and 6 of 10 between the ages of 73 and 94. So a lot of very frail people, people with cognitive challenges, mild to moderate dementias, as well as some complex comorbidities. Most of our clients do live alone. And we provide a basket of services that's tailored to the interests and needs of the clients. Everything from transportation, Meals on Wheels, assisted living, respite care for family caregivers, congregate dining programs, diversity programs that are ethnically specific to certain communities where there might be some challenges that seniors have, and a number of other areas that are designed to support our vision, which is to enable seniors to live independently in their own homes, safely and with dignity as long as possible, keeping them out of long-term care, keeping them out of hospital and emergency rooms. So let's look at the case study, the Home at Last program. And this has actually been around for just over 10 years now, and it came out as a result of challenges back then with a backlog of seniors inappropriately in hospital beds. A study that looked at some of the causes for that found that there was a shortage of long-term care beds that led to the backlog. There was a lack of proper processes in hospitals to ensure timely discharge. There's a lack of focus on a smooth system in transferring patients if they needed to transition. And finally, that there was a lack of community services for recently discharged patients. And that's really where Home at Last developed. Initially as a pilot project. It's no longer a project. We consider it to be one of our foundational programs that we offer. And certainly there are other organizations in Ontario that offer similar Home at Last types of programs, but I think ours is probably one of the most developed. Some of the outcomes that we set for ourselves are to ensure that obviously seniors are not staying in hospital any longer than needed, helping support the hospital with timely and safe discharges, and preventing unnecessary readmissions among them. From the standpoint of our hospital partners, we're looking to support them in improving the patient discharge experience, providing seamless transitions, reducing readmissions to hospital emergency, improving patient flow. So we will work very closely with flow navigators and discharge planners, nurse practitioners, and so forth within the hospital. And finally, to also improve our collaboration among the hospital partners that we serve and other community support organizations. So how does it work? When a patient is ready for discharge, and this program is available 365 days of the year, so we work through all of the statutory holidays between the hours of 8:30 and 4:30. So whenever a patient is ready for discharge, we will get the referral from whoever in the hospital is making that, responsible for that discharge, and one of our personal support workers goes directly to the hospital. The eligibility is 55 plus, and patients need to be able to weight bear. And that's mainly because when they get home, we want to make sure that they are able to transfer safely from the vehicle into their home. On the way home, the personal support worker may stop and pick up groceries. If somebody has been in hospital for some time and don't have any groceries, they'll stop and pick up prescription drugs. When they get to the home, they'll make sure that the electricity is on, that the telephone is working, that there's heat. They also do a safety check in the house. So they're checking to make sure that there's no potential trip and fall hazards in the home, that because the client is a little unstable. So it's also a safety check for them. We also provide them with 2 free Meals on Wheels meals, so that they have something that's readily available for them to eat, to make sure that they get that nutrition. So what does it look like in terms of the numbers? We partner with 4 regional hospitals and 7 bordering hospitals. We also partner with other community support agencies, with supporting them with cross-border transfers, training, sharing of best practices, and so forth. The client profile, in the last year, we served over 1,500 clients. The average age is 76. The average time for referrals that we get from the hospitals is noon time, perhaps not surprising to some of you. 281 of those were emergency room discharges. 585 of the clients live alone, so again, demonstrating the need for someone to provide them with that support and settling service. And in our own survey that we do of all clients, they report a very high satisfaction with the service. So we took Home at Last, or HAL, and mapped it against the characteristics and dimensions that Chang and Catallo had developed. And for the most part, we were able to tick off all the boxes, but where we found that there were more challenges was the area of sharing of information, an appropriate measurement system. We do our own measurement, but it's not sort of a shared responsibility with the hospital partners, and accountability and responsibility. The Home at Last program is seen very much as a chat service, as opposed to something that we share accountability and responsibility with our hospital partners on. In terms of some of the ongoing challenges, we're constantly having to do education, awareness as staff and hospitals turn over in the different areas and wards. So it would be very helpful if we were to have a designated in-hospital champion, which we don't have in our for hospital partners right now. There needs to be a little bit more clarity around the referral process and respective roles. Sometimes there are still assumptions made by the people in the hospital as to what the program does and how it works. So again, part of that continuous education that we need to do. And there's sometimes breakdown in communication about the patient referral. There have been times when our personal support worker will present to the ward and we can't find the patient. It may be that they've gone down to the cafeteria for a coffee, or that they happen to run into a friend and the friend says, "Oh, I'll take you home." So we do have patients sometimes MIA. And as I said, the degree of collective ownership and accountability is something for Home at Last outputs is something that we would very much like to develop as part of our integrated care. So what's on the horizon? As I mentioned, we have a new government that is introducing a health system modernization with a focus on ending hallway health care. And part of the focus will be on a fully integrated system through the development of Ontario Health Teams, or OHTs, that will serve catchments of about 300,000 through bundled care and local planning initiatives. It really will be an opportunity for community support organizations to be more fully integrated into service coordination and planning, shared outcomes, quality measures, and accountability as a result of these person-focused teams. And as a final note, CHATS is already engaging in one hospital-based prototype that is focused on frail elderly population with multiple comorbidities. And it's using the Home at Last premise to support transition to home, which will be followed by appropriate wraparound care for a period of 16 weeks. So thank you very much for your time and attention, and I hope I've been able to share some new ideas with you, and I'll be interested in any comments or questions.
Thank you, Christina. That was excellent, an excellent project in Hull. In Scotland, we would say that Hull sounds as if it's a great community pal for helping people transition from hospitals. I thought your slide on challenges was particularly helpful, and it's sort of reflective of the challenges we're experiencing in Scotland as well. But to go down to the extent of having someone in a person's home to even check that the electricity's on, make sure there's a couple of meals there in the fridge or the freezer, is fabulous. Mm-hmm. That amount of detail is excellent. Any questions from the audience? Yeah. Any questions? I mean, what about the challenges that were on Christina's slide there? We go back to the slide again. Is there anything that perhaps prompts a question or an observation from any country here that has, yeah, good. I've got Louise Kelly from Scotland. I know Louise. Thank you. Thank you, Louise.
Hi, Louise Kelly from Scotland with an Irish accent. Yeah, I guess it's not really a question, but a comment on reflecting what you were saying there in terms of that, you know, you're talking about healthcare, you're talking about social care, but you're actually talking about real people's lives. And I was really impressed by that detail, because the reality of going home and having something to eat, and the heating is on, and to stop on the way back to get, as we all would, to pick up bread and milk from the shop or whatever. It just seems like it's a very personal and very human model that you've developed. And I was just wondering, you know, that doesn't come out of the sky, how you involved people themselves in coming up with your model and deciding what would work. Because I'm sure that wasn't developed by people sitting in a room somewhere.
Yeah. So we try and engage our clients in co-design to the extent possible, but it was also something that did evolve over time. There are similar models where, for example, the agency will send a driver to the hospital to pick up the person and bring them home, and then the PSW or personal support worker will go into the home. That was an example that we found that we were just adding another transition point for the clients. So from the feedback that we got, clients said that they would much prefer to have the person who meets them in the hospital, the person who is with them throughout the process. There's also, I didn't mention, but we have a 5-day check-in where there's an opportunity to provide additional hours of service in any way that the client or even the caregiver may need, if they need some respite hours, that we developed, because clients were saying that, you know, they like the idea of knowing that in a few days' time somebody is going to come in and check on me again, as opposed to, you know, we're settling you at home and then we're done. You won't see us again necessarily. So those things, through, you know, the 10 years that we've been running the program, we've identified with our clients ways to improve the service to them, and addressing the social determinants of health through that as well.
Thank you, Christina. That was a lovely question. Thank you. Or observation as well. Anybody else, very quickly? Or we will, yeah. From Ireland.
Des Mulligan again from Ireland. I think you had a statistic there of something like 491 emergency department referrals. That's an incredibly responsive service to be able to respond to, you know, I have somebody here in the emergency department and they need to go home.
Yes.
Can you come and pick them up? That's very challenging. So, I mean, are you able to respond to all emergency department referrals? How do you plan your workforce around that level of responsiveness?
Well, we have dedicated staff for the Home at Last program. So they are serving all of the hospitals. And in the case of emergency room, we do have certain eligibility criteria. So there may be situations where somebody is ready to be discharged that just doesn't fit or can't be supported. But for the most part, we are able to respond to all of those challenges. We do keep our own metrics, so we track the number of units, obviously, of service. And when we see that there's a dip or even a spike in a particular hospital, then we have that conversation with them, like, why aren't you referring people? And sometimes that gives us some pretty good learning too, that could be the time of day that is a challenge, and they have so many people that want to depart at noon, for example. But for the most part, we are able to accommodate all of that demand.
Thank you very much. Good question again. Thank you. Well,